Lifespan Center for Digital Health seminar series. As you guys know, our center is focused on developing and disseminating evidence-based digital health tools that make a difference for patients and populations. And as part of that, we try to do both internal presentations around kind of the latest and greatest stuff that's happening here, as well as external presentations to expand our skill set, our sense of what could be possible, and our awareness of the latest and greatest science. So with that, I'm super excited to have Dr. Schueller here. I have known him, I think we met at an NIH, probably at an NIMH conference, like almost a decade ago.
We met at the services conference. I can't remember when, but it felt like forever ago.
I think we were both on K's at the time.
That's exactly right.
Yeah.
Yep. We remember the story the same way, so it must be true.
Yeah, it's perfect. Exactly. Our memories are into, we did not confirm this beforehand. But I've always been impressed by Stephen's work. It's some of the neatest stuff that's out there around mental health, digital mental health interventions. And Stephen has moved, when we first met, you were at Northwestern, or you were somewhere else maybe, and then you went to Northwestern and now have moved to UC Irvine, but remains kind of one of those people that I keep a publication alert on, so that I know when you're publishing new stuff, because it always just expands my sense of what might be possible. And so I'm really excited to hear where you are at now. I know that you're doing some neat work around evidentiary standards in digital mental health, both in collaboration with industry and independently as a scientist. And so I'm really, really excited to have you here giving this talk today. So welcome. I wish it were in person. Someday it will be. And I'll let you kind of take it from here. The last thing that I'll say is that, and I'm sure Justin said this, but normally, feel free to not fill the full hour with slides. We're happy to do Q&A. Folks always have lots of interesting questions. So I will mute myself and take it away. Welcome.
Very good. Well, thank you so much for the very kind introduction. And I feel fortunate we were on K Awards at the same time and got some opportunities to meet you that way. And definitely, I'm very excited to give this presentation to the Brown Lifespan Center for Digital Health. I think in the after times, I'll have to find some time to actually come to Brown. I've never been to Rhode Island. I hear you guys do weird things with coffee and milk or something, but would be very excited to come at some point. So I'm going to give a sort of broad overarching presentation that talks about some of the work I'm doing generally, but also really focusing on trying to think about how we sort of better understand the digital mental health space, because I think that we're at a really important paradoxical crossroads here where we have a lot of product development and a lot of knowledge generation, but I worry sometimes that we're not learning the right things to be able to actually impact and improve people's lives. And so I think that in the goal of trying to understand how do we advance evidentiary standards, I think that we have to think about what digital health affords us and sort of new opportunities. So just a little bit of sort of broad overview introduction in terms of the work that I do. And I think that this is helpful to frame some of the things I'm going to talk about in terms of evidentiary standards. Is I'm a person who's worn a couple different hats and do a lot of different things in the area of digital mental health, both across my career and then also kind of currently in the work that I do. So not surprisingly, I've been in this space for a little bit. I launched my first digital health intervention in 2006, and the world has evolved a lot in that time, and digital health has evolved a lot in that time. And essentially at that time, we were putting PowerPoints and PDFs on websites and calling it digital health. But it was a really interesting opportunity to expand the reach of our products. Since then, I've done work developing different mobile interventions. So while I was at Northwestern, I helped develop a suite of mobile apps that was referred to as IntelliCare. This was a couple different apps, mini apps that each had sort of a unique behavioral intervention strategy within the app. So we had a sleep hygiene app, and we had a cognitive restructuring app, and we had a goal setting app. And they were managed by this hub app to be able to recommend and personalize packages or treatment sequences for people. I've also worked in terms of doing co-design, of coming up with sort of novel ideas for new interventions in collaboration with different stakeholders. This picture here in the middle comes from a workshop, a series of workshops we did with middle schoolers to design happiness technologies. This was one of my favorites. This was the mindfulness backpack. It had It would have this like hugging technology where it would be able to squeeze the person who is wearing it. It would have a good smell emitter. And if you want to know what good smells were to middle schoolers, it was freshly baked chocolate chip cookies and the smell of their own bed. They were very big talking about their own beds and sleeping. It was a very important mental health aspect for middle schoolers developmentally. And then lastly, another sort of example, some of the work I did developmentally is working with youth experiencing homelessness in Chicago to develop a mental health intervention leveraging smartphone apps that was what we called the stepping stone intervention. So a lot of work at the sort of development of these tools. But more recently, my work has sort of moved more to the implementation and the partnerships and the understanding of how the different tools they're developed by industry partners and other folks in the ecosystem can be brought in and integrated into healthcare settings. So actually here in California, we're doing a very ambitious and innovative project where the state is integrating digital mental health products into 15 counties across California. It's called Help at Hand. It includes large counties and small counties, counties like our own here in Orange, Los Angeles County, small counties like Modoc, Inyo, Tehima, places that, despite me being a native Californian, I had never stepped foot in besides this project. And I think it's really raised some interesting questions and learnings to sort of think about how we can actually use these tools in real world settings. And just as some of the examples of some of the products that are being implemented and evaluated in this Help at Hand project, Headspace is one. It's being actually offered to any LA County resident as part of this project currently. And My Strength, which is a cognitive behavioral therapy platform. I also serve as the executive director of One Mind PsyberGuide. And One Mind PsyberGuide is a project I'll talk a little bit more about, but effectively it's like a Consumer Reports or Wirecutter of digital mental health products. So we identify, evaluate, and disseminate information about digital mental health products on a variety of different metrics. And so when I think about evidentiary standards, this is sort of the framework and the background through which I think about these aspects. Through my own work is developing some of these things early on. And one of the reasons I think that that was important at that time is there weren't a lot of products out there. Digital mental health was a very sort of open area. People hadn't developed these products. But now as there's been an evolving ecosystem, which I'll talk a little bit more about, I think our role as scientists is often to sort of think about how do we separate the good from the bad? How do we think about, developing evidence in this space? And then how do we actually get these tools, if effective, into the hands of the people who need them? In the spirit of that, and also understanding that some folks in the audience here may not know the digital mental health space as concretely, I want to talk a little bit about some of the evidence and some of what we do feel like we know in this space currently. And some of this builds off of a forum that I was part of that met at the Banbury Center about 2 years ago. And we recently released a consensus statement that came from this group. It was organized by David Moore, a colleague of mine who I worked with at Northwestern, as well as Pat Arion, who leads an NIMH P50 Alacrity Center at the University of Washington. And essentially this report came with, offered 3 recommendations. The first being that guided digital mental health interventions, so that means digital mental health interventions that are provided along with some form of human support, should be frontline interventions for depression, anxiety, and post-traumatic stress disorder. And I'll talk a little bit more about why we propose that should be the case in a second. The second point, and not one I'll talk about as much in the talk, but happy to answer questions or have some conversation about this because I think this is a really important area, is that digital mental health interventions should be reimbursable. We should make it possible to be able to pay for these tools in sort of standard reimbursement pathways. And I think one of the reasons that this is such a critical recommendation is that if no one's going to pay for it, we're not going to get it implemented. We're not going to get it sustained. And so I think the payment models in this space is something that really needs to be thought about and developed. And then lastly, and I think that this is a place where I'll spend some more time talking about in this presentation, that evidence standard framework should be created to support digital formularies and decision makings. If we're going to implement things and if we're going to reimburse things, we need some way to determine what are quality products, what are quality interventions, such that we know what to provide to people and what to pay for. So as I mentioned, there's a lot of evidence that suggests that digital mental health interventions are effective. And this is going to be a little bit paradoxical later in the presentation, because I'll note that although we have a lot of evidence, we know a lot, we also don't know a lot. But over the past 2 decades, there have been over 200 randomized controlled trials that show that these digital interventions, especially when in combination with some form of human support or professional guidance, are effective for a variety of different things. They're effective for depression, they're effective for anxiety, they're effective for stress, and they're effective in improving quality of life. What you see on the right side of the slide here is some comparisons between the effect sizes that we find in meta-analytic data for all these different metrics. And you can see that overall, it looks really good for depression, anxiety, stress, and quality of life with these per human supported or guided interventions. And in fact, those, sorry, actually the axis dropped off here, but the effect sizes for guided interventions tend to be on par with what we see in face-to-face treatments in these same areas. The effect sizes are much smaller for unguided or self-guided interventions, things that you might use by yourself, go download on the App Store, or use an intervention or web-based platform with no sort of human guidance before, in addition to it. So although these tools might be useful from a public health perspective, you could reach a lot of people and provide some level of care, they're not ineffective. The standard of care seems to be most consistent with traditional treatments when we have that sort of human guidance or that human support. This is another table that comes from a recent meta-analysis that Rina Karatoka did. It's an individual patient level meta-analysis, which means that they combined the individual data from all these trials to be able to look at some more important moderator variables. And I think that this table really illustrates this point quite nicely. This is a really great meta-analysis looking at the use of digital cognitive behavioral therapy for the treatment of depression. The point I want to make from this table, and I thought a point that's really useful in this meta-analysis, is that for some individuals, so if you look at case number 4 here, and that's for individuals with low levels of depressive symptoms, you see that the guided intervention and the unguided interventions are both equally effective. And so in some cases, for some people, we might actually be able to use unguided interventions as increasing the standard of care. One thing to note, though, is this is looking at a patient health questionnaire 9, which is one of the most standard metrics to sort of understand and assess depression. Usually individuals with below a patient PHQ-9 of 10 is not someone who would be referred to traditional services. We might engage in watchful waiting. We might sort of see if those symptoms exacerbate. But usually you're sort of thinking about a PHQ-9 of 10 or greater in terms of someone being needed for treatment. And when you start to see at that level, and it gets more significant and more discrepant as you go up in the PHQ values, is that you see more of a differentiation between the guided and the unguided treatments. And so for individuals, with the PHQ-9 of 25 here, which is, a quite severe level of depressive symptoms, you see that the guided versus unguided intervention is far superior. Sorry, the guided intervention is far superior to the unguided intervention. So what this study shows us, and what I think the predominance of evidence suggests here, is that these tools, when provided with human support, are as effective as traditional treatments. That unsupported interventions might work for some people and might have a role in terms of thinking about from a public health perspective. But if we think about where we want to make the recommendations, and again, to go back to that Banbury Forum report, we have really great evidence to suggest that digital tools, especially those based on cognitive behavioral therapy, where most of the evidence exists, can be effective and should be frontline treatments in the areas of depression, anxiety, and post-traumatic stress disorder. Another thing to note is that this is being done around the world. If you go to the UK, if you go to Australia, if you go to Canada, if you go to Europe, you'll see that digital tools are being used as frontline treatments for these disorders and being done, quite effectively. And so I think, just thinking about where we are in the United States, we're lagging behind the adoption of these tools to be able to help tackle the burden of mental health disorders that exist. So because of this, there's been a lot of focus on sort of better understanding what are the different effective tools that are out there. This recommendation comes from an NIMH work group report that came out a couple years ago, and they sort of noted in that report that we should evaluate existing mental health apps, that numerous mental health apps are available online, but there's a need for rigorous evaluation and development of an evaluation structure for these different applications. I think that many people think that that this regulation might be accomplished or might be done through FDA. But I note that the FDA has been largely absent in this space, at least currently. So the first FDA-approved behavioral health product was approved back in 2017, and this was Reset by Pear Therapeutics. And since then, we've had actually, I need to update the slide. There's another FDA product that was approved more recently, but we have what I usually refer to as like 3.5 new products that have been approved in this space by the FDA. We have Reset O, which is my half. It's an opioid-specific version of Reset. We have Endeavor RX, which is a video game for ADHD. We have Somrest, which is a digital cognitive behavioral therapy platform for insomnia. And then we have Nightwear, which is the one that's not listed here, which is an Apple Watch treatment for PTSD that makes use of trying to intervene with sort of nightmares that people are experiencing. There's a couple reasons why there has not been that much approval in this space. One of the reasons is that many apps, or the products that we're often interested in, the types of products we're often interested in the digital mental health space, fall outside of the focus of FDA's regulatory oversight, or the FDA has chosen to exercise enforcement discretion over those products. So here are some examples. I'll give another example, a little bit more of a detailed example on the next slide, but things that help people self-manage their conditions without providing specific treatments or treatment suggestions, or products that provide people with simple tools to track health information. These are the types of products that the FDA has said that they are not going to either fall outside of their regulatory oversight, or that they are going to exercise enforcement discretion over in the space. Essentially, that they're not going to evaluate and they're not going to regulate these types of products. This is a further example. This comes from the appendix for the FDA guidelines in this area. And so they note here that a software functions that help patients with a diagnosed psychiatric condition. So for example, post-traumatic stress disorder, depression, anxiety, or obsessive compulsive disorder, maintain their behavioral coping skills by providing a skill of the day behavioral technique or audio message that helps the user can access when experiencing increased anxiety. And I think the form of a lot of these interventions that we're talking about take this type of form. They are meant to be used for someone once there's been an identified mental health condition. So they might get assessed or diagnosed by a provider, referred by an existing sort of treatment setting, and passed over to these digital interventions. And for these interventions, the FDA has said that they're not going to regulate them. And so I think that we can't rely on FDA or rely on FDA approval to be able to, or that it's going to approve or regulate all of these products. Another thing to note is that the FDA actually released a notice last April that said in light of the COVID pandemic, they were actually suspending review and regulation of all products in the digital, in the sort of psychiatric mobile health space. And so since last April, we've actually seen a pause on review of these FDA products. There's been some discussion of whether or not that notice is going to continue. I've heard some people think that they think it's very likely. I've heard other people think that it's a very strong likelihood. So I think time will tell. But I think one thing to really, note is that even if that notice gets rescinded and they go back to the previous review processes, there's still a lot of area in which this space is not being regulated. So I note that what I say is that, that makes finding a good app or finding a good digital mental health product a little bit like finding a needle in a haystack. We're left without a lot of information to be able to guide different decision makers, consumers, clinicians, providers, and payers to be able to decide, what to download, what to use, what to pay for, and what to provide. So this is a little bit of the problem that we try to address through One Mind PsyberGuide. So One Mind PsyberGuide, as I mentioned, is a project where we identify, evaluate, and we disseminate information about digital mental health products to various consumers. The overall focus of One Mind PsyberGuide is to be consumer focused. So the products that we traditionally have reviewed at One Mind PsyberGuide are products that a consumer could go download for themselves from the App Store without the need for a prescription, a referral code, or the purchase from a employer. We do this by reviewing products and then using some different metrics I'll talk about in a second. And we look at how those products align with established metrics. And then we provide those scores on our website and also disseminate them through other opportunities. And we send that information back to the developer. So after we review a product, we send the information to the developer and let them know that we've reviewed them, ask if there's any sort of discrepancies or are there any information they'd want to share. And hopefully through doing so, encourage app developers to raise the practices that they're engaging in terms of the use of evidence and the different information that they're sharing when they disseminate their products. These are the major metrics that we evaluate products on through One Mind PsyberGuide. The first thing we look at is credibility, which answers the question of how likely is it that this app will work for me? We look at the direct and indirect evidence for a product, which I'll talk more about in a second, because I think that's really critical and important as we think about the evidentiary standards here. We look at the different developmental processes that product went through. What was sort of the degree of stakeholder involvement and early sort of evaluations looking at aspects of feasibility and acceptability. We then look at user experience. This answers the question, how likely is it they'll actually use this app? Digital tools are effective insofar as someone actually adopts and uses the tool. And we know that a lot of digital tools, especially in the digital mental health space, don't enjoy sort of long-term sustainment or engagement. We see, very steep attrition curves that many people who download a product never open it. And 2 weeks after initial use, we see usually across products about 40 to 60% of people have abandoned, who started using that product have abandoned it. And so I think that user engagement and user experience is really critical and a really important aspect. And so we evaluate this component using the mobile app rating scale, which looks at aspects such as functionality, engagement, graphical design, and other elements to figure out if it's easy to use, easy to learn, and easy to continue to use. Next, we look at transparency, which reviews the data security and privacy policies to sort of better understand what will happen to my data if I enter it into this app. Now, I'll note that we call it transparency rather than data security and privacy itself, because we do a review of the data security and privacy policies that the developer provides. We don't do a technical audit of the app itself. So if for example, if an app says that they encrypt the data and it's stored in a password protected server, we don't try to hack into that and sort of determine if that's true. Now, I do think that there's some evidence that suggests that that might be something that would be useful. For example, Kit Huckville and John Toros published a really great paper a couple years ago, where essentially they put a piece of software on the phones to see where the data was going from apps and analyzed some popular smoking cessation and depression apps. And they found that a lot of the apps were actually not following their privacy policies, were sending data to other third parties that wasn't noted. So I think that there is some value in doing so, doing a technical audit. It's just not something that we do through One Mind PsyberGuide. I'll note that even though we don't do that, there are huge discrepancies in terms of what information is shared in data security and privacy policies, or even if data security and privacy policies exist. We published a paper a couple of years ago where we reviewed about 120 different depression apps. We found that about half of those didn't even share a data security and privacy policy. And for many of those, even if it did have a data security privacy policy, you couldn't actually even see the policy until after you already entered some information into the app. You had to set up your login account with your email and demographics before you could actually get access to the privacy policy to tell you where that data might be going. And so I think that this is an area where there's a lot of discrepancy, and understanding those privacy policies, I think, is useful. And then lastly, we have some apps that are provided along with professional reviews, which offers a narrative review about how to use this product. A lot of these products don't come with instruction guides or manuals. They might have FAQs, but those are created by the developers and maybe don't hold all the information that a consumer might be interested in about the clinical relevance, the clinical importance, or the clinical background that contributes to that app. So we have a professional that's independent of that app, usually someone with some expertise in the content area. So if it's an app for insomnia, someone with expertise in the treatment of insomnia, or someone who's done work in the digital health space overlapping before, write a review that kind of talks about, what are the pros, what are the cons, what is the background behind this idea, and what are different ways you might be able to use this type of tool in your life. I'll note that the professional reviews are actually some of the most popular content on the One Mind PsyberGuide website. A lot of times people come to our website because they're searching for, reviews of a popular mental health app, review of Calm, review of Headspace, and they see the professional review that exists for that product, and then they come to our site from that web search, and then they look at other aspects of our site. So I think that this also, despite the fact that we think this is valuable, it does seem like this is an area where consumers are really interested, which I think is an important aspect of the One Mind PsyberGuide project. Just as a bit of an example of like what these reviews look like, this is a review for Happify, so you can see that what platforms it's available for. You can access it from your desktop, from an Apple or Android device. You can see our credibility score, which is scored out of 5, our user experience score, which is scored out of 5, and our transparency score that's scored on a sort of in 3 different buckets. Things are either rated as acceptable, not acceptable, or questionable. And then you can see that for this product, a professional review is available. We also tag these products in a variety of different aspects to be able to help folks better search and filter or find things that are related to what they're looking for. So we tag things based on different conditions that it's proposed to work for, different intervention methods that are present in the product, and then also different populations for which it's designed. And this is what you'll see if you, for the professional reviews. You can see that this is not the full professional review. This is just the top of it, but there'll be some screenshots and some descriptions and some pros and cons. Just a little bit more about how we disseminate information through One Mind PsyberGuide. We also work with a variety of different organizations. We work with the International Obsessive Compulsive Disorder Foundation, the Anxiety and Depression Association of America, Mental Health America, the American Institute of Stress, Association of Behavioral Cognitive Therapies, American Psychological Association, and some other organizations, both to get some information from these organizations about what products are they interested in having reviewed, or what products are the consumers interested in. We also share our reviews that get disseminated through some of these organizations' websites. So for example, if you go to the ADA website or the IOCDF website, they do have app reviews that are present on their sites for the content areas that they're interested in. OCD for the IOCDF Foundation, anxiety and depression apps for ADAA. But those reviews are reviews that are done through the One Mind PsyberGuide team and through our One Mind PsyberGuide system. And so in some ways, we're trying to help sort of provide some additional information into the ecosystem to folks who are interested in this. We also review, release different products. This is an example we released last year in collaboration with the Northeast Business Group on Health, where we reviewed about 24 different enterprise digital mental health programs that were intended for employers. And so what we have, the sort of focus or the key sort of part of this guide is a comparative table of those 24 different products that looks at different aspects of like, what is the population it's intended for? What are some of the different features to share data? What is the evidence or the research base? What are the different intervention types? And so again, just trying to provide some information to the fields to better guide decision-making and help people understand, what different products that are out there and what are the comparisons between different products. Because something that we've heard often from employers is that they get pitched a lot of these different products. And of course, all the companies say that their product is the best and has all the features and it's doing everything. There are a lot of good products that are out there, but there are also a lot of differences between these products. And so better allowing people to compare things, I think, is something that's really useful and necessary in this field. So I want to dive in and talk a little bit more about evidence standards then, and specifically about the way we think about credibility, somewhat from the vantage point of One Mind PsyberGuide, but also somewhat from the vantage point of, what I see kind of going on in this field kind of currently. And I want to make have a little bit of a conversation around the difference between direct and indirect evidence, because I think that a lot of times, especially in the academic community, we really value or I should say overly value direct evidence. We want to see the randomized control study that was done on that specific product, but we don't appreciate that indirect evidence holds a lot of value, and especially in this space, and is something we often rely on or using to be able to make decisions and guide decisions. And so I think we need to better understand the trade-offs that exist between direct and indirect evidence, and also appreciate that valuing indirect evidence more highly might be able to facilitate a better use then of real-world evidence to be able to guide decision-making and create understanding. So I'm going to just talk about kind of 2 quick case studies about different ways in which direct or indirect evidence have been used, and some of the pros and cons in terms of how we think about direct and indirect evidence, and then talk a little bit more generally about sort of evidence standards that I think we need to be advancing as a field. So this is a direct evidence case study example, and this draws from Lantern. So Lantern is a digital cognitive behavioral therapy platform. They were very early leaders in terms of the digital cognitive behavioral therapy space. And they came out with this fantastic paper that was published last year. It's like one of my favorite examples of a rigorous trial on a digital mental health intervention, where they did a randomized control study of using this digital cognitive behavioral therapy platform with specific content for eating disorders called the Student Body's Eating Disorders Program across a set of over 50 different universities in the United States. And across those universities, they were able to randomize just under 700 women to different conditions, and we're able to look at the comparisons between this digital cognitive behavioral therapy eating disorder program with a control condition. And they found that there was a significant difference, and we got better impact and better effects from the digital cognitive behavioral therapy platform than the control condition. And this was published last year in JAMA Network Open. So should be success for the Lantern platform, right? Well, if you know the space at all, you might know that Lantern actually closed down in 2018, and that this trial was conducted, between 2014 and 2020. It took them 6 years to run this randomized control study. And so although this shows good evidence for the fact that digital cognitive behavioral therapy can be effective for the treatment of eating disorders, it doesn't actually help guide decision-making to be able to have payers or people be able to go get this Lantern product. Lantern lives on in a couple different products. Ginger, Spring Health, and some other folks have licensed aspects of the Lantern content. And so you might see Lantern present in other products, but the support for this specific product no longer, is not as useful from a decision-making point of view. And so I think that this shows some important trade-offs that exist when we think about the use of direct evidence. Randomized controlled studies are great. They can really show us that a certain type of intervention is feasible, and that we could be delivering certain types of interventions for certain types of disorders. But randomized control studies are often slower to conduct, and maybe the pace of the study is not commensurate to the pace that's often done in sort of product life and product development. And so we see here that although we have good evidence that Lantern, is effective, we no longer can actually go purchase the Lantern product specifically. So now I want to move on and talk a little bit about indirect evidence. And I think as a case study, I think Pear Therapeutics, which has done a lot of the work around FDA-approved products in the digital mental health space, I think has some good examples of some different uses of indirect evidence. And specifically, I want to talk about sort of Reset and Reset-O, but also this is work that they're doing with Somrest. So as I mentioned, these are some of the only products that have FDA approval in the behavioral health space. And I think one thing that's worth noting is that the FDA approval for these products is actually based off of a lot of data that came before these actual products. So Reset and Reset-O, for example, came from data that came from the therapeutic education system, or Lisa Marsh's work, developing an internet cognitive behavioral therapy platform for substance use. And so there was multiple randomized controlled trials that were done of this TES platform. And after those trials were conducted, Pear licensed the content to be able to put into Reset. A similar thing was actually done with Somrest. So Somrest builds off of Lee Ritterband's Shut Eye program, which again was an internet cognitive behavioral therapy platform for the treatment of insomnia. And Pear licensed that content to be able to repackage as Somrest to get FDA approval and to get dissemination. And so I think one thing that's worth noting here is that in a lot of places in the digital health space, we accept the fact, or we accept the level of evidence that if you validate a certain program and show that a certain type of intervention is effective, and translate or repackage that in sort of a new format and can demonstrate that new intervention shows fidelity with the previous intervention. It's the same content, the same stuff, the same levers, and has a sort of adequate level of safety and acceptability, that it seems like it's reasonable and feasible to be able to disseminate that to individuals in ways that is going to make practices and interventions more available to people in need. And I think a point I make a lot of times in this space is that if we think about practice more generally, we evaluate interventions and we license professionals. And I think that we have to sort of think a little bit about how we might be able to use that model or that metaphor to spread effective interventions and use indirect evidence and then real world evidence effectively to be able to think about what we're evaluating and what we're considering in this space. So as we move to think about that, I think that this is an example of just thinking about what different levels of evidence are necessary in different aspects of medical decision making. And I think what's worth noting here is that there is not a yes/no binary decision. It's not that randomized control studies and meta-analyses tell us everything and other data tells us nothing. But that there's different strengths of evidence that exist across this continuum. And that we have to sort of think about in this space, what level of evidence has been generated in an area, and what level of evidence is possible through a digital intervention, and how we might be able to supplement the existing evidence base or advance knowledge that we already know through integration of real-world evidence or other aspects of that can be collected through the use of a platform. So there are sort of three areas that I think are really important then to consider as check marks as we sort of try to advance evidentiary standards and better start to utilize real-world evidence criteria in digital mental health interventions. I think we have to think about risk, which is what is the real risk to consumers who might use these products? What is the stage? And by that, I mean, how much evidence exists for that specific intervention and that specific digital platform? The use of that intervention in a digital platform. So for example, as I showed, the lantern example, we have a lot of evidence to suggest that cognitive behavioral therapy works for eating disorders. We have some good evidence to suggest that digital cognitive behavioral therapy works for eating disorders. And so what we probably need in the future studies is indication that we can have similar outcomes from digital cognitive behavioral therapy platforms for eating disorders when we show fidelity with the types of interventions or the types of mechanisms that are present from the interventions that have been evaluated. We're never going to continue to, we're never going to advance this space at the speed we need to and help people if we continue to require a randomized control study for every single new instantiation of a product or in every new sort of digital cognitive behavioral therapy platform that comes out there. That's not to say that RCTs are not useful or that are not necessary. And definitely there's a lot of places where the innovation through technology is going to be able to create new and novel interventions, and those should be evaluated. But we have to sort of think about the stage and the maturity of the research evidence. And then lastly, like trying to think about scale to what populations and what contexts are we trying to scale and move sort of new interventions. So I think one thing though that's really necessary then is we try to move from clinical trials to a real world evidence framework is we also need to better unpack what's going on or what we think is going on under the hood of these types of interventions to get at a more mechanistic understanding or to do mechanistic evaluations of the types of things that are present. We proposed somewhat of a model like this in a paper I wrote with David Moore, Enid Montague, Michelle Burns, and Parisa Rashidi a couple of years ago that was published in JMIR, in which we proposed this behavioral intervention technology model where you would differentiate between what are the clinical aims, so what is it you're trying to do with the intervention. In this example, we sort of walked through MyFitnessPal and talked about the goal to reduce caloric intake. What are the behavioral strategies that map onto that? And then what are the technological elements that make those behavioral change strategies part of that digital intervention? And I think if we have better mapping of these mechanistic models and better description of what we're proposing these digital interventions can do, we can measure those different levers in a real world evidence paradigm to better understand what's working, what's happening, and whether or not we're ultimately leading to the clinical benefits that we want. Very similar arguments are made in implementation science. And so I think there's a lot of opportunities to bring together some thinking about implementation science with real world evidence in the digital health space to move to concepts such as fidelity, adoption, sustainment, to understand those levers in these interventions as we sort of think about real world evidence. So I think that what I'm proposing and what I think that we need to think more about in the digital health space is that when we think about these evidentiary frameworks, we need to do so around a couple different questions. It's not just clinical outcome, that's important, but we also need to think about levels of risk, current states of evidence practice and current states of evidence and current states of practice, and under which cases are we proposing that these products are going to be used. So in conclusion, we know a lot, but unfortunately, the evidence that we know doesn't always map on to what we need to know. And so I think that one of the things that we need to better appreciate as academics and as researchers in this space is that there's a difference between evidence-based decision-making, so being able to make a decision based on the research that's out there, and decision-based evidence-making, so being able to run more studies or do more evaluations that actually answer the questions that individuals have when they're evaluating and making decisions around adopting a product. I'm going to say something here that's probably atypical for an academic, but I really do believe it, is that the absence of evidence is not the evidence of absence. Good things might exist that we haven't tested yet, and we don't know what we don't know. So I don't say this because I'm proposing that we don't evaluate things, but I don't think we can completely dismiss different products that have not been evaluated yet just because they haven't been evaluated. I think we have to think about how we actually do rigorous evaluation, but also make use of multiple types of evaluation, not only the randomized control study. And we also can't stifle innovation by only recreating non-digital services. So I think that an evidentiary standard that says like we're only going to allow digital versions of existing treatments is going to miss the mark, because there's lots of new things that are available to us through technology, but those things require a higher standard and a higher benchmark for testing. So lastly, I just want to, in that frame of that thinking, one thing I want to call for, and this is one of my favorite pictures and favorite papers, and I use this in nearly every presentation, is as I note, we need to think about how we align evidence and innovation. We also need to avoid skeuomorphic thinking. And so what a skeomorph is it's a something that shows up in a new format, often a digital form, because that's the way we did things in the past. So I've got a couple examples here. The Gmail icon, which has an envelope. We don't put our emails into an envelope and seal them, but we have that there because that's how we used to do things, and it has this nostalgia and this remembrance factor, or way to sort of note or draw parallels with sort of previous forms. Or these light bulbs on the chandelier that look like candle flames. Those light bulbs could be any shape we wanted. They could be hockey pucks, they could be dinosaurs, but we make them look like flames because that's what we used to do. We would take a candle and we would light it. And I think that this sort of skeuomorphic thinking is problematic for the interventions that we build. We can't just build interventions that takes the traditional way we did things and moves it into digital format, 50-minute sessions, or these long sort of didactic sort of stuff. We need to think about what technology offers us. And similarly, we can't skeuomorphically get attached to the randomized control study. I've got this figure here. When you've got a hammer, everything looks like a nail. When you're trained to only do randomized control studies, it really looks like everything should fit that box, and that's wrong. We need to really appreciate that there's a panoply of different evidence and generation techniques, different trial designs, different ways we can understand things. And that real world data does not mean naturalistic observational studies. We can do more sophisticated methods and more sophisticated things, but we need to first, I think, address the evidence standards, what people are willing to accept in this space before we're able to really sort of accelerate the use of those different techniques. And with that, I'll just say, thanks everyone for your attention. Here's my contact information if people are interested. This is where I live here in Irvine, so folks should come visit sometime. It's really pretty out here. And I think we've got some time for questions now.
Perfect, thank you. Way to tempt us with that picture. That was terrific. So I would love to hear your thoughts about and I saw that Jim Padbury put some questions in the chat as well about your thoughts on alternatives. So one of the challenges that I face when you're looking at the non-RCT, people talk a lot about, say, N of 1 trials. Those don't work for behavioral interventions, right? You can't put someone on the intervention and then take them off, depending on the type, but they're less likely to work than with other types of digital interventions. So I would love to hear your thoughts on some of those alternative standards outside of just saying, well, other people have done this before, so this is likely to work as well.
Yeah, well, I will just comment quickly on the N of 1. You saw my little head shake. Although I agree with you, we did a small N of 1 study with some colleagues. Eric Heckler was involved, Ida Sim, and we were doing this in the behavioral intervention space. And I do think it was a really interesting study and a really interesting experience. I think one of the things actually we talked a lot about, which I think is something that would be useful for us to think a little bit more about as behavioral interventionists, is especially the folks on the team who were more used to doing these types of things with medication studies. They ask us questions about what's the washout period for your intervention, and how long do you need to see an effect? And it's we don't know any of these things. And so I think some of the challenges with N of 1 studies is we actually just don't know enough in behavioral interventions. But I do think that if we get a little bit better at sort of specifying some of our mechanisms of action and some of the smaller steps that exist within those behavioral interventions, we might actually be able to create sort of better N of 1 studies to sort of answer sort of questions of interest. So I do think that some of the need is just to think smaller and to sort of open up the black box of our behavioral interventions, and to although I think, kitchen sink approaches are often useful because that's what leads to real, to big behavior change, because different things work for different people. And, human beings are complex. Within these digital interventions, we often have the potential to actually maybe specify some of those different levers and to evaluate different pieces of the intervention within an N of 1 design.
Almost an RDoC framework for digital mental health.
Yeah, that's exactly right. And I think that there's pieces of that in the ecosystem in terms of I think multi-phase optimization strategies that really get us to think a little bit more about what are the components. If you start with a MOST design, when you move on to the RCT, you can still sort of think a little bit more modular and mechanistically about the different pieces that are present there to make sure your theories are being confirmed in their using. And you could, approach some of those from either an N of 1 paradigm or an A/B, doing some more interim A/B testing or smart designs or things of the sort. So I think that's one way to sort of think about this. I think to sort of answer your question a little bit more broadly, Megan, and not, I think you're right that N of 1 designs are not sufficient. And so I think some of the other things that I think are really sort of useful in terms of control conditions to think about here is to try to do different aspects with like sequential randomization designs where we have a sort of test period and then we revert back, the whole population to a sort of previous version or a different type of intervention. Or, for example, to use, some different methods of, creating similar control groups like propensity score matching. I think there's a lot of ways to sort of think about, what's present here. I think the one thing that I do think we need to do in digital health more generally is we need to move beyond wait lists. Like we can't just compare things to wait lists. We need to actually have sort of more rigorous designs. And I think we're starting to see this. I think that's one reason I really like that the study coming from the Lantern group for the eating disorders is that they did have sort of a very nice, control condition, which in a large study, which I think is often not present in digital health. And it blows my mind a little bit that people talk about the potential for digital health to recruit these like large samples. And I still see so many studies, even from companies and industry people that have a lot of people using their platform where it's like the report on 20 people, they report on 100 people. And they're like, we have 1 million people use our platform. And here's data from 10. It's like, what does that tell us? And who are these 10 people and why do I care? So I think that's just another thing we need to think about as we think about these comparison conditions is, what segment of the population do the different comparisons and the folks sort of exist on. And if a company would say like, well, we have 1 million people and we were able to get full data on 100, those metrics look like to the similar metrics you're seeing in these samples. And so I think also having some different designs where you have some data that's consistent and then you sort of extrapolate to sort of other sort of data sources that are present is another way to sort of think about, again, this mechanistic thinking here.
I love it. Jim, you had a question.
I enjoyed your talk. My question was also about design, and I put my hand down because you're kind of addressing it, but it just seems to me the control group in the PsyberGuide lab, the controls are just as important as the experimental group. And it seems like usual care isn't a legit control group, but if that's a straw man, in your view, you can shoot me down. But it seems like the controls are...
Yeah, I think it depends on what the study is, Jim. Like I agree with you. I think in sometimes usual care is not a very sophisticated control group. So, one thing we've done in some of our studies is that, if we were using a digital intervention, or I think we have to sort of rethink what, usual care might be. So if we're using like a digital, like a mobile health app, you can easily go to the, the Google Play or Android store and download, you put in depression, you put in anxiety, you can find an app. And so I think it's, you have to sort of sometimes think about like what would be the usual care that someone might be getting if they're sort of interested in this digital sort of health space. And so we've used in some studies like a mood tracking app as like a comparison, because it's like, okay, this is something that people think, people are interested in. Tracking is like one of actually the major reasons why folks turn to digital health interventions. I have not seen any data that convinces me that mood tracking by itself, though, is useful for a lot of the things I'm interested in, depression, anxiety.
I would think something that employs EMA, and in one side there's an intervention and the other side there's less, that would control for human contact and other motivational.
Except
if you're doing the
Jim,
EMA in the intervention group, for sure.
Yeah, I would say that EMA is part of the intervention. So that's why, like, we can get into like a theoretical argument here, but kind of on the data that I have from my studies that the EMA itself is, the kids also, my participants all say in the qualitative components that, I know it was a robot, but I felt like someone was really checking in on me.
I agree with that, Megan. We heard actually pretty consistent things with like the work I did with like the youth experiencing homelessness. There was a significant like EMA component. And actually that was the stuff they liked the most. We had sort of two phases in that study, and it was a little bit sort of head scratching to me about like why we spent so much money in the first phase building some of the app components, because they told us they liked like the messaging and like the easy stuff. And I was like, well, if that's what you want, we'll tear out all the other stuff and we'll give it to you. But so I think we do have to think about
that's evidence.
Yeah, for sure. But so I think we need to think about what is the intervention, what do we think it is? And I think that, we need to test these things and then you move on and change it in the next one. And so again, that's why I think like building things up, sometimes from these most designs is really nice in this space.
Thank you very much.
I want to give other folks a chance to ask questions as well. I know that we have some students and trainees who are still on the call. So if any of you have a question, feel free.
Can I ask a question?
Go for it.
My question is not, first of all, very interesting talk, got me to think really, but my question is not towards the design or experiment of or how to evaluate digital mental health app. But from my experience, I've seen that there are not a lot of apps for managing borderline personality disorder. And I was wondering why, do you have any ideas why is that so? Like there are so many for depression and anxiety and stress, but when it comes to cluster B personality disorders, I don't find a lot of apps.
Yeah, I think that probably two reasons. One is marketing, that there's a lot of folks with depression, anxiety, and a lot of these companies are trying to, get some portion of the, population that's out there with who's experiencing these different things. And so I think especially early on, like a lot of products were kind of going for like the large populations. And I do think we're actually seeing a shift in that in the field. There's a little bit more like niche seeking and opportunity looking. So I do see more products trying to fill the gaps. But I do think just especially like early on, like people were taking swings at, the disorders that more people experience. And I think number two is I think safety. A lot of places are very risk averse. And so they're looking for products that don't have as many sort of safety concerns, and individuals with borderline personality disorder have more of a tendency to engage in, self-injurious behavior and other things of the sort. I think we need to be doing more digital stuff in the space. I think there's a lot of showing that people are interested and it's helpful. But I do see a lot of places where they're very risk averse. And I've had conversations with people around, the PHQ-9 item 9, where they don't want to ask about it because they don't want to get sued. And it's like, asking saves lives. Asking allows us to do things. We should ask. And so I think that that's a pretty poor reason, because I think that we can mitigate safety concerns appropriately. And I think a lot of work is, Megan's done great work in this area of working with, people that are experiencing things that people might, other people might consider risky. But I do think that's a reason why we've seen less development here.
Stephen, I want to be respectful of your time. I know Tally has her hand up, and I want, if you can stay on, I welcome you to kind of talk to her. I do have to run, unfortunately. I'm so sorry. It was so wonderful to see you, even remotely. Digital connections are a gorgeous thing. Really appreciative of your leadership in this space and your willingness to share with us today. And one quick question before I go is, we did record the seminar. Are you okay with us sharing it with folks and or posting on our website? So
yep. Ask me ahead of time, so that's great. And I can hang around for your question, Tally.
All right, thanks.
Great to see you though, Megan.
See you soon, hopefully.
Sometime in the after times.
Exactly. See ya. Bye.